Hi, my name is Linda Johnson. I'm here to present a case study on the microorganism Haemophilus influenza for my MLS 461 class. A male 76-year-old patient arrived into our emergency room complaining of acute pain left shoulder, extreme fatigue, and high fever. He had never been a smoker and had a history of hypotension and diabetes mellitus. He did in fact have a fever of 103, his blood pressure was 97/50, and his respiratory rate of 23 breaths per minute noted with crackles in lower left lung. His WBC count was greatly elevated at 28,600, and his C-reactive protein was high at 25. He had body fluid drainage from a pleural fluid. It was yellow, and the analysis showed a pH of 7.4, a total protein of 5.2, LD of 4,491, glucose was 66, and on the cytology smear, it was dominant neutrophilia. On the microbiology workup, respiratory aspirates were collected and plated in micro accordingly with a blood agar plate, a McConkey agar, and a chocolate agar in CO2. There was no growth on McConkey or blood agar. However, there was growth on the chocolate plate that was incubated in CO2. It had a small, clear, colorless, moist colony with a distinct mousy odor. Additional tests were done, gram-negative bacilli on the gram stain, and a beta-lactamase test was negative. I've included a flow chart that will help us narrow it down to probably a Haemophilus species. We did do sensitivity. The organism was sensitive to levofloxacin, piperacillin, ciprofloxacin, and gentamicin. It was resistant to ampicillin. I inoculated quad plates. The quad plates contain 4 quadrants, one that has 5% horse blood agar, one that has X factor alone, one with V factor alone, and then one with X and V factor. My plate, in fact, grew on the horse, 5% horse XV agar, and the X and V agar. None grew on the X factor or the V factor alone. Here is a chart that shows the probable reactions for the different Haemophilus species, and here is a picture of my plate and the growth pattern that I recovered. A little bit about the patients. We also had a influenza antigen test that was positive that went ahead and put a diagnosis of influenza virus-related secondary bacteria empemia due to Haemophilus influenza. His treatment was drainage of the pleural effusion, and then he was also administered pyramil, which is like the antiviral for influenza, and piperacillin and tazobactam every 8 hours for 14 days. Upon discharge, his WBC count had dropped into normal range, 7,600, and his C-reactive protein still slightly elevated, but down considerably to 4.46. He was given oral levofloxacin to continue on for the next 2 weeks. A little bit about the Haemophilus influenzas. They are small, pleomorphic, gram-negative coccobacilli. They may contain a polysaccharide capsule. If this capsule is present, the strain may be differentiated to 6 types, A through F, based on the capsule's biochemistry. Strains not possessing the capsule are termed non-encapsulated or non-typable H. influenza. However, the most virulent strand of H. influenza is the type B Hib, but due to all the vaccine that most young people are getting today and older, we do not see that as much. We see more of the non-typable H influenza. The common signs and symptoms of the Haemophilus influenza sample infection would be Hib meningitis, cellulitis, epiglitis, Hib pneumonia, Hib pericarditis, septic arthritis, occult bacteremia, and then in neonate infections, there's bacteremia, sepsis, meningitis, pneumonia, respiratory distress, and conjunctivitis. There's also mucosa infections, including otitis media and conjunctivitis. Most common laboratory testing is the gram stain of the body fluid or the infected site, bacterial cultures, and then sometimes slide agglutination tests for specific antisera or serotyping. The acute phase reactants also, the elevated erythrocyte sedimentation rate, and the C-reactive protein. However, I do understand that the ESR, the SED rate, is not used as much. In conclusion, a non-smoking patient presented with pneumonia-like symptoms, elevated WBC count, and C-reactive protein, and pleural effusion. His diagnosis was achieved within a few days with microbiology cultures, and after 2 weeks of antibiotic treatment, the patient's labs were within normal range, and he was discharged with additional antibiotic prescription. I did have a few difficulties researching my case study. Due to HIPAA regulations, this presentation was based on an online study. The case was chosen for the similarities in symptoms, results, diagnosis with a patient that I observed in my own facility. The plates and the organisms pictured were inoculated by me. Thank you for your time.